very good afternoon to all of you. I am Dr. Pramod Kumar, and on behalf of the Department of Geriatric Medicine, I welcome you all to this CCR Threads of Complexity Weaving Solutions for the Elderly. So, today I will present an interesting case. It's a case of an older adult who presented to us in a bedbound condition last year in October. And it's not a very rare condition or a very unique diagnosis. It's a very common diagnosis actually, but it's the complexity that we dealt with in management, in diagnosis, that we'll discuss here. And I'm sure that by the end of the CCR, we'll have some good learning points to take away. So with that, we'll start with the CCR now. We have with us Dr. Shrutika JR, who will be presenting the case, and Dr. Shreya will be presenting the review of literature. So we'll start with now Dr. Shrutika.
Good afternoon, everyone. I'll be presenting the very complex case which we encountered in our ward. The case revolves around a 77-year-old male who is a retired government official, who is a resident of Delhi and known case of varicose vein peripheral neuropathy with the CAD. He was maintaining his usual activities of daily living 1.5 months back. Until recently, he had a fall in the washroom while urinating, which was 6 weeks back, and since then he was being bedbound. His fall was witnessed by his son. It was without any loss of consciousness. He remembers the incidents and there was no signs of any injury. There was no pre-syncopal symptoms which was prior. During the event, there was no limb jerking, fecal incontinence or urinary incontinence. Post-fall, the patient was well oriented and was not able to regain his usual mobility and was walking with the need of the support. So total number of falls which he had in a year was 3. In the January 2024, he had a fall with a prior dizziness that led to the fracture of the right sided of the femur, which was managed conservatively and he regained the mobility after 2 months. Next to fall he had in the month of August. First fall was in washroom, likely environmental, and the second fall he had while getting up from the bed. Sir, it was in the washroom, so environmental fall. That fall was not, there was no prior symptoms. When he had a fall, his son noticed the large wound beneath the right MTP joint. In the outside hospital, debridement was done under the spinal anesthesia. This is the wound our patient had, and he was completely unable to walk and gradually become bedbound and become dependent for its ADL. His condition further deteriorated and he presented to the hospital with a history of altered mental status and reduced verbal output for past 7 days. So there was no history of any memory complaints or slowness in walking or focal neurological deficit or limb stiffness, no history of palpitations or chest pain, no history of any alcohol dependence, no history of low mood or anxiety, no history of joint pain or muscle pain, and no history of vision or hearing impairment that could have led to the fall. He is a case of a varicose vein for past 30 years, peripheral neuropathy for past 5 years, and in July 2023, he had undergone PCI for the STEMI, but there was no hypertension, diabetes, and the CVA. In the personal history, the patient was non-alcoholic and non-smoker with the vegetarian diet. His appetite was reduced, and he had a history of significant weight loss, which reduced from 88 kg to 78 kg in 1.5 months. His sleep was normal, bladder was continent, and bowel habits were altered. So is that it? With a recurrent fall in the background of coronary artery disease and peripheral neuropathy and varicose vein, or there is always more to the story that could have led to the recurrent falls. In the treatment, we have found out he was taking more than 5 drugs. So polypharmacy was present in our patient. And at presentation, his both basic as well as instrumental activities of daily living were impaired. He was not even able to feed himself. Further, we did the comprehensive geriatric assessment, which showed that our patient was malnourished and delirium was present. He was with the compromised mobility. He was at a risk of sarcopenia. He was severely frail and multimorbidity was present in our patient. His vision and hearing was normal, bed sores and elder abuse was absent. Vitals on admission were normal. His GCS was E3V4M6. He was drowsy but arousable. On general examination, pallor was present, pedal edema was present, and there was a 4x4 centimeter wound beneath the right MTP joint. In the systemic examination, we found out that there was a fall in the systolic BP, which was more than 20 mm of Hg, even in the sitting position. because he was not able to stand. In the respiratory system, it was normal, and abdominal system examination was also normal. Further, in the CNS examination, as he was having delirium, after improvement in the delirium, we assessed for the cranial nerves, which was normal. Motor system showed the reduced power in the lower limb than in the upper limbs. Knee jerk and ankle jerk were absent, and plantar on the right we cannot elicit because wound was there, and on the left it was mute. In the sensory system examination, fine touch, vibration, proprioception, pain sensation, and distribution. Pain sensation all were impaired, and it was distributed more distally than in the proximity. There was no cerebellar signs and no signs of meningitis. So, in a summary, 77-year-old male patient who is a known case of coronary artery disease, varicose veins, and the peripheral neuropathy. He presented to us with a recurrent falls and his post-fall worsening with the altered mental status and reduced verbal output. He got completely dependent for his ADLs. So we divided the diagnosis into two key questions: that why our patient would have recurrent falls. Is it related to orthostatic hypotension secondary to drugs, or autonomic neuropathy, or related to peripheral neuropathy, or was it related to anemia? Anemia due to any malignancy or chronic condition he might be having, or was it related to malnutrition? Second thing, why he was having delirium and why there was an inability to walk. Was it related to pain which was related to fracture, or any acute CVA, any active infection he might be having, or any electrolyte imbalance? On top of this, our patient was having this geriatric syndromes of malnourishment, delirium, with the compromised mobility. He was sarcopenic, he was severely frail, and multimorbidity was present. So we did the baseline investigations, which showed the hemoglobin of 8 with the severe hypocalcemia, which was asymptomatic, along with the hypomagnesemia. Albumin was very low, which was just 1.6. PTINR was deranged, and dyslipidemia was there. We further found out there was an iron deficiency with the transferrin saturation of 11.4%. So for orthostatic hypotension, he was already on the beta blockers and diuretics. We further did the AFT, which showed that a fall of 46 mm of Hg, even in the head up tilt position. Anemia workup, we did stool OB, which was negative for 3 times. Peripheral smear showed the normocytic hypochromic anemia. B12 folate levels were normal, and multiple myeloma workup was negative. For suspicion of malignancy, we did the tumor markers, which showed the CA125 and CA19.9 were mildly elevated. So for the delirium, his electrolytes corrected, and potentially inappropriate medication we discontinued. To rule out any fracture, ortho review was done and X-rays were done. Wound swab we sent for the culture sensitivity, which came positive for the Citrobacter, and he was started on the antibiotics linezolid and tigecycline. NCCT had been done to rule out cause for the altered mental status, which showed the age-related involutional changes. And bilateral lower limb arterial Doppler we did for the trophic ulcers, which showed the atherocalcific changes in the bilateral lower limbs with the severe stenosis of the right ATA, which should be managed conservatively. So for radiological investigation, I would like to call Dr. Harshit, Radiology SR, for the further discussion.
Thank you, Shri. So, going in the sequence of investigations which was performed, the outside NCCT said there was no gross changes other than the age-related involution changes. So, to confirm the findings, the MRI was done. As it confirmed, it also showed same age-related involution changes. There was no any infected lesions, no any neoplastic lesions in the brain. There was no hemorrhage or infarcts. Along with the MRI screening, even the spine screening was performed just to rule out any nerve compressions or neuropathy symptoms. So it was also grossly normal. There was no nerve compression or any cord lesions. In the ultrasound abdomen, however, we found out that the patient had the nodular outline and nodular texture of the liver with mild ascites, confirming that he had early developing chronic liver disease.
This was mild ascites and it was borderline enlarged spleen, confirming the portal hypertension. As already said, the patient was having AD occlusion. Rest of the arteries also showed blood flow, but however, there was laterocalcific changes throughout the. On 5th of November, CCT was performed, which provided a new finding. It showed that there was evidence of pancreatitis in the patient with this heterogeneous attenuation and the fuzzy margins of the pancreas. So this was the perihepatic fluid. There was bilateral fluid effusion, and there was few bony islands in the skeleton, right-sided abdominal wall hernia, and there was this right-sided proximal femur fracture. This is radiological finding.
Thank you, Dr. Harshit. We further, as we have found out in the radiological investigation that our patient was having CLD. So we further worked up. There was still suspicion of malignancy in our patient with the edema and symptoms of loss of appetite and loss of weight. For cause of hypoalbuminemia, we did the urine ACR, which came out to be normal. And for cause of CLD, viral markers were negative. Autoimmune hepatitis markers were negative. Ferritin was low. There was no KF rings. So cause of the CLD was attributed to the metabolically associated steatohepatitis. To rule out the varices, we did the UGI endoscopy, but it revealed the surprise of esophageal candidiasis. We further worked up for the polyneuropathy. HbA1c was 5.4, which was falsely negative. Endoscopy showed the no evidence of diabetic retinopathy. Urine ACR was normal, and RBS monitoring was also normal. So hidden type 2 diabetes mellitus was ruled out. For the inflammatory workup, ANA was 1 plus with the ENA profile being negative. CSF autoimmune panel was also negative. We also sent urine and serum toxicology, which came out to be normal. And for paraneoplastic workup, we sent the CSF and serum paraneoplastic panel, which came out to be negative. And finally, we did the PET-CT to rule out any hidden malignancy, which may have contributed to the polyneuropathy. So we did the PET-CT. Now I would like to call Dr. Kunal, the nuclear medicine SR, to further discuss on the PET-CT imaging.
Thank you. So this patient underwent an 18F FDG PET-CT at our department on the 26th of October. This is the maximum intensity projection image, and we can see that the most striking finding is this increased uptake bilaterally in the neck. This was in the bilateral sternocleidomastoid muscles, and this was likely biomechanical due to exertional breathing. Apart from that, we can see that there is increased uptake in the region of the pancreas and the upper abdomen. So on the fused axial PET-CT images, we can see that this uptake was actually indeed localized to the pancreas, and it was present diffusely throughout the pancreas. On the CT, there was no definite focal lesion. There was, however, as Dr. Harshit said, peripancreatic standing and some evidence of pancreatitis. Apart from that, there was evidence of fluid overload, so bilateral pleural effusion, evidence of past PCI. You can see abdominopelvic ascites here in the perihepatic, perisplenic regions. While there was no focal lesion in the liver, there was diffuse parenchymal hypoattenuation. Ancillary findings, there was particularly the left side kidney was a little shrunken. There was increased perinephric standing. We've already spoken about this hernia in the right lower abdominal wall. And there were multiple non-FDG with tiny sclerotic lesions and this fracture in the right femur, which we've known. The liver span was about 16.3, 16.4 centimeter. Spleen was also borderline 11 centimeters. And this is the FDG PET brain. Here we can see that there's increased uptake in the bilateral basal ganglia and the brainstem, midbrain and brainstem. And this is the Z-score map. This basically highlights the areas of reduced FDG uptake or cortical hypometabolism when compared to an age-matched normal population. And here also we can see that there is actually bilateral, a little more pronounced on the left compared to the right, but bilateral reduced FDG uptake in the parieto-temporal regions and also in the frontal view. So with this, we had given the impression that there was diffuse pancreatic hypometabolism, tiny sclerotic lesions in the pelvis and few dorsolumbar vertebrae, bilateral pleural effusion, abdominopelvic ascites with borderline organomegaly, and with the history of polyneuropathy, we had suggested that a possibility of Poem syndrome needs consideration.
Thank you, Dr. Kunal. So, was it we considered the possibility of Poem syndrome? But was it really Poem syndrome? As polyneuropathy was present with the organomegaly and skin changes of hyperpigmentation was there in our patient, but endocrinopathy and monoclonal plasma cell disorder was absent. So Poem syndrome we ruled out. So at the tip of iceberg, we can see the recurrent faller with these comorbidities, but beneath the iceberg, we found out many conditions which were acute, like delirium, secondary to distal electrolytemia, hepatic encephalopathy, acute interstitial pancreatitis, acute kidney injury, and drug-induced thrombocytopenia. Last two developed in the hospital and which resolved also on the background of the chronic conditions like peripheral neuropathy, which was chronic mixed fibers, axonal, sensorimotor with the autonomic neuropathy, with the trophic ulcer and orthostatic hypotension, along with BPH, coronary artery disease, and peripheral artery disease, iron deficiency anemia with the hypoalbuminemia, and esophageal candidiasis. On top of this, we also got the geriatric syndromes like osteopenia. He was malnourished, he was severely frail, and with the impaired functionality. So, managing the comorbidity is not just the case in our geriatric patient, but we considered what matters most to our patient. That we tried to improve their cognition, mobility, medications, and multi-complexity, like in this case. So, for delirium or hepatic encephalopathy, electrolytes were corrected, rifaximin was given, regular bowel movements were ensured with the laxative, IV albumin was given, and reorientation therapies was done for delirium. For pancreatitis, it resolved after 48 hours. IV fluid support was given, and gradually we built up the nutrition. IV fluids were given for the AKI, and antibiotics were de-escalated after decline in the inflammatory markers. For the orthostatic hypotension, he was taught maneuvers to prevent falls. Abdominal binders was given, and his mobilization improved with the regular physiotherapy. For peripheral neuropathy, he was given medication for his positive symptoms, and deep tissue laser therapy was given. For the trophic ulcer, he was advised using diabetic shoes and daily dressing was done. And for coronary artery disease and peripheral artery disease, antiplatelets were given along with the statins. For as he was having iron deficiency anemia, we changed the dual antiplatelet into single antiplatelets, and he was supported with the transfusions and iron injections. Fluconazole was given for esophageal candidiasis, and this is how multimodal rehabilitation therapy was initiated for our patient. Now I would like to call Dr. Shreya, SR Geriatric Medicine, to further discuss about the review of literature.
Thank you, Dr. Shrutika. We move on with the review of literature. So let's begin with what a fall is. A fall is an event which results in a patient inadvertently falling from the ground or to a lower level. Older adults who fall more than once a year are considered recurrent fallers. It has been found that 26 to 37% older adults in India experience at least one fall every year. Falls are considered the 14th leading cause of disability-associated life years in older adults. It has been estimated that around 45,000 rupees was spent every year on older fallers due to hospitalization, hence signifying the importance of secondary prevention to improve functionality and improve the quality of life of our older adults. In studies based on the longitudinal aging study of India data, it has been found that older adults over 80 years of age, and particularly amongst them women and those with chronic comorbidities, were at the highest risk of suffering from falls. Also, older adults who were having physical frailty were at a high risk of falls. Also, those who are having multimorbidity, like our patient, were at the highest risk of suffering from falls. Amongst the consequences of falls, the highest or most important were the physical consequences. Fractures, particularly hip fractures, were seen in these older adults. 75 to 80% of hip fractures were said to be associated with fall history. Traumatic brain injuries, amongst them 20 to 25% were found associated with falls. They could also lead to significant pain and discomfort, as well as prolonged immobilization. It was found that around 78 for every 1 lakh population of older adults had actually died because of unintentional falls in India. Social consequences like loss of independence and dependence for aliens, and psychological consequences like fear of fall were also associated with recurrent falls. Moving on to the risk factors for falls. Falls can be due to multiple extrinsic and intrinsic risk factors. These include medical conditions like stroke, Parkinson's, dementia, medications, psychoactive, multiple medications such as an our patient, the use of diuretics, psychosocial and demographic factors like a previous history of fall, ADL limitation, physical inactivity, and advanced age in itself could contribute to falls. Apart from this, sensory motor and balance problems like muscle weakness, impaired vision, reduced peripheral sensation, and environmental factors like poor footwear and home hazards could contribute to falls. Moving on to the fall assessment, the first and most important question is to ask regarding falls. Like in our patient, since he had multiple episodes of falls in history, we directly moved forward with a gait, strength, and balance assessment. Since the patient was not able to perform a timed up and go, and he had more than 2 episodes of falls, we went for a multifactorial risk assessment. This included a complete physical history, examination for postural dizziness, medication review, cognitive screening, assessment of the need for assistive device, foot and footwear, and visual acuity. Following this evaluation, we went for an individualized treatment group. So what are the single interventions which are available? These include exercise and physical therapy. So the United States Preventive Services Task Force as well as the American Association of Physicians recommend physical exercise. They recommend 30 to 90-minute sessions 1 to 3 times a week for a duration of 12 minutes minimum to show improvement in fall risk. Vitamin D supplementation has been found useful in community-dwelling older adults. The American Geriatric Society recommends 1,000 international units of vitamin D in addition to calcium supplementation for older adults. Medication review has been found to improve fall risk by up to 39% by educating patient and caregivers. These include reducing drugs such as psychoactives, antidepressants, anti-Parkinsonian medications, and removing drugs like diuretics when not indicated. Apart from this, home safety plays a very important role in reducing fall risk. These include advising patients regarding the use of grab bars, sticky mats in the bathroom, adequate lighting, and reducing uneven floors to reduce fall risk. Vision correction where necessary, converting from multifocal to single focal lenses while climbing stairs has been found useful. Foot care, which includes foot-based orthosis, exercises, and using appropriate footwear, and pacemakers in patients with carotid sinus hypersensitivity has been found useful. Amongst the multifactorial interventions, we have standardized assessment of risk factors, patient-specific care plans, and patient and staff education. Multifactorial interventions were found most useful in extended care or rehabilitation settings. Individual trials have suggested that they reduce fall risk by up to 30%. So, a comprehensive geriatric assessment was also performed in this case. This is a multidimensional holistic assessment of an older person. It takes into consideration the health, the well-being, and thereby formulates a plan to address the issues which are of importance to the patient. As compared to usual care, various studies suggested that a CGA intervention was useful in improving both the quality of life and reducing caregiver burden in community-based older adults. In systematic reviews and meta-analysis carried out, it was found that CGA increased independence and reduced mortality risk in older persons who are admitted in the hospital, particularly those with frailty. Moving on to the domains of CGA. There's a medical domain, that's functional assessment, psychological assessment, environmental assessment, and advanced care planning. Amongst the medical assessment, we have physical examination, review of the medications, an in-detail nutritional assessment, bone health assessment, and pain assessment. Amongst functionality, we have certain components which can be used to assess the basic activities of daily living like the CATS and the Barthel scale, and instrumental activities of daily living like the Lawton scale. Psychological assessment we have done including the cognitive assessment, assessment for depression and presence of delirium. Environmental factors like I mentioned for home safety and accessibility to social support, as well as advanced care planning, which means discussing the values, preferences and goals of the patient in such situations wherein they might not be able to take decisions for themselves. So in our patient, we went for a physical rehabilitation, which included balance and gait training with the assistance of our physiotherapist, muscle and strengthening exercises, the use of assistive device like the walker, and home safety interventions. Nutritional rehabilitation, we started the patient on high protein, high calorie containing diet, and we gave supplementation when it was indicated. We also gave psychological rehabilitation to the caregiver and the patient. So at presentation, like we had seen, our patient was not performing any of the basic activities of daily living. But at discharge, we found that he was able to feed by himself and he was continent. And further, at follow-up after 2 weeks, we found that he was able to feed, dress, transfer, toilet, as well as perform instrumental activities like use the telephone, transport with the help of a relative, take medicines on his own, and manage his finances. So this is the video of the patient at his home after being discharged, where he is able to independently mobilize with the help of the walker. This brings the important concept of healthy aging to mind. So healthy aging is what we define as the process of maintaining the physical and mental abilities of an older person despite their aging process. Like we see, healthy aging is dependent on maintaining the physical abilities, the social ability, healthy nutritious diet, the underlying genetics, and productive. Now I'd like to call upon Pramod sir to give the concluding.
Thank you. So, as we saw, this was quite a complicated case. So, patient presented to us with recurrent fall in a bed-bound condition and delirious condition, and we tried to solve the issues one by one. So, most of the time, what happens when patients come with fall-related injury, doctor will treat the acute event, and the fall evaluation is not done usually in most hospitals. So, but it's very important to treat the underlying cause of fall, because in that case, the patient will go home, will have another fall, and may present with more serious injuries. And as we have seen the consequences, head injuries, fractures, laceration, all that can be present. So it's very important to evaluate for the underlying cause, and usually it's multifactorial. We have the intrinsic factors, we have the extrinsic environmental factors as well. And for that, we need to have a comprehensive geriatric assessment to assess for all the causes of fall. The patient also developed certain complications while treatment because of drugs like thrombocytopenia, pancreatitis also maybe because of drug related, but those improved with treatment. And finally, as fall is a multifactorial, we also need a multimodal intervention for fall prevention, which include treating the underlying cause, regular physical exercises, dietary supplementation, etc. So now the patient is more functional, even if he's using a assistive device and an abdominal binder to prevent a sudden drop in BP, but he is able to do his basic activities at least on his own. So that's what we aim for, a better quality of life for this patient. So with that, I would like to end. Special thanks to the Department of Radiology, Nuclear Medicine and Physiology for helping us with the diagnosis. Also Department of Orthopedic Surgery and Gastroenterology and Neurology who helped us with assessment and management of the patient. And our wonderful team of physiotherapists and dietitian who helps in the rehabilitation of the patient. So with that, I'd like to end.